And my internet is working today. I don't know about the rest of you, but my power went out for like a while in the middle of the night. All right, there we are. Okay, so today we're going to be thinking about some of the factors that affect pulmonary ventilation. So last time and over the last couple days or week or so, we've been thinking about pulmonary ventilation, breathing in, inspiration, breathing out, expiration, and the pressures that we look at as we think about that. Now we're going to be thinking about some things that can change how much pressure you might need in order to breathe, some things that can make it harder, honestly, not too many things that make it easier, but some things that assist in the breathing process as well, without which we'd kind of have some problems. Okay. So I asked you guys to take a look at the concept of compliance again before we talk today. So I want to put that in the context of your lungs, right? So when we've talked about compliance before, we talked about it, maybe a little bit of a mention with the heart, but we definitely talked about it with our veins and arteries. So we know that compliance is this measure of a relationship between volume and pressure, right? So for our highly compliant structures, we've got something that can be easily stretched out with only a little bit of a change in pressure. Versus something with low compliance, those are typically going to have pretty high pressures and not much change in volume associated with that. Uh, So our lungs are typically going to be highly compliant. So we want them to be kind of like our veins in that way. We want them to be easy to stretch out because if they're not, it gets harder to breathe, right? So if they have low compliance, that means that in order to get a larger volume of air, right, you need a much higher pressure. And there's only so much pressure you can exert with your diaphragm and those external intercostal muscles expanding your chest, right? So it's important that we can stretch out our lungs. So we could technically calculate out our lung compliance, and this is how we would do it. So up here we see the change in volume that we'd be looking at. So we're thinking like lung size there. We've got our smaller lung when we've got a small thorax, and then the larger as we expand and breathe in. And here we have the change in pressure that we're working with, right? So this is a relationship between volume and pressure. And we know some of our lung pressures, right? So we can see that the specific change in pressure you'd be looking at here might look a little bit familiar, right? Because this is actually how we were calculating our transpulmonary pressure. So that distending pressure across the wall of the lung. So we had this PALV, that's our alveolar pressure, right? So the pressure inside our little alveoli. I'm just going to draw some lungs again so that we can label on where these pressures would be, right? So not amazing lungs, but all right, this is where we had that alveolar pressure. So that was the one we looked at to determine whether we're going to see inspiration or expiration when we compare it to the environment. And then we had that intrapleural pressure in the pleural sac surrounding the lungs, right? That keeps them kind of suctioned to the rib cage. And now we have this pressure difference, the transpulmonary pressure across the wall. Right, so this pressure difference across the wall of the lung, that transpulmonary pressure, is what has to pull our lungs open ultimately. It has to distend them, has to change their shape, right? So that's how we would measure our lung compliance. So if this quantity is larger, if the lung compliance is larger, what that means is we can get a greater volume, right, for that same difference in pressure, that same transpulmonary pressure. But if our lung compliance drops, right, suddenly with that same transpulmonary pressure, that same difference in pressure across the wall of the lung, we're not going to get quite so much volume, right? That's what a low compliance number would mean for our lungs. Right? So we like our lung compliance to be pretty large. Okay. So we have some factors that affect that lung compliance. So one piece is that we have a trade-off. Always, this happens in our arteries too, a trade-off between elasticity, so like that bouncy property of tissue, of lungs, right? Bouncing back is more elastic. And something that's more elastic is by nature less compliant, right? Again, I find it helpful to compare this to the arteries and the veins, right? The arteries are elastic, they bounce back when you pinch them. The veins are compliant, but they're just those kind of flat backs when you see them in the body. Yeah. So we'd have a trade-off in the lungs as well between the elasticity of our lungs and their compliance. And we also have to take into account the surface tension in our lungs. Okay. So to understand that, right, surface tension, we want to think about the air that we have going into the lungs, and therefore the air that we have in those alveoli, right? So that air, we've humidified it as we took it through our conducting zone, right? So we breathed in through our nose, through our mouth. That air traveled into the pharynx, down through the trachea, through those bronchi, into the lungs, splitting and splitting and splitting, right? Humidifying and warming. So in our alveoli, we have some water. And water has this tendency to try to kind of clump up, right? You might have done this in a chemistry class in high school, or I don't know if they do it here in college, but where you put little drops of water on a penny and you see that it makes a little dome from the surface tension. You might have done other similar experiments, right? But if not, you can just know that because that water is a polar molecule, we've got this surface tension. Water tries to kind of pull towards itself. Um, so we have to fight against that in order to keep our alveoli open and in order to expand them as you breathe in, as you inspire. Yeah. So we've got this thin layer of fluid in the alveoli, some of which is going to be water that is going to be a force for the alveoli to kind of collapse and pull inward. But this is where we also see the importance of surfactant. So remember when we talked about like type 1 and type 2 alveolar cells, and the type 1 alveolar cells making up most of the wall of the alveoli, and I mentioned that the type 2 cells are going to come back later. This is where they come back. So that surfactant is going to be important for breaking the surface tension between the water molecules in the alveoli, which is going to help the alveoli stay highly compliant. If we have greater surface tension from that attraction between water molecules, that would make our lungs less compliant, so more sort of collapsing and harder to expand, harder to create a nice big volume with just a little difference in pressure. Right. Okay, so that surfactant is going to be important for breaking our surface tension. It's coming from those type 2 alveolar cells. Okay. And it's acting kind of like a detergent, basically. So it gets between our water molecules and breaks them up. It interferes with their attraction to each other, right? And the end result is that you can breathe easier. Okay. So what we're looking at here are some alveoli, and we've got a comparison between what we would see in a situation where we have no surfactant in the alveoli here on the left, right, versus the situation we very luckily, hopefully have in our own lungs, where we have sufficient surfactant. So what we're looking at on this left-hand side here, right, we've got two alveoli picture. So our alveoli are like bunches of grapes. So they're all bunched together in groups. And not all the alveoli in a grouping in this alveolar sac are the same size. So we're looking here at two alveoli that are different sizes. And we're looking at the water molecules that are trying to pull those alveoli closed, like on purpose, but just because water molecules create surface tension, right? Okay. So this equation we have up here at the top is looking at the pressure you need to resist tension given a specific radius of an alveolus, right? So we've got a size, we've got an amount of tension, and we've got a pressure here. Okay, so what happens here, right, is that these differing sizes of the alveoli end up having this result where the surface tension, because of these different radii, means that you need a kind of higher pressure here to keep an alveolus open versus a lower pressure in this larger one to keep the alveolus open. So without surfactant, we'd have the air moving towards this alveolus that it's easier to keep open here, right? So we have this lower pressure in this larger alveolus. So we can see that comparison here, low pressure P2 compared to higher pressure P1, right? So we've got this kind of high-low gradient, right, which we would need to stop these from collapsing. But then we have a pressure gradient, and we know gradients drive airflow, right? So all the air would end up moving. We don't want that to happen. We want to be able to use all our alveoli, no matter how large they are, right? So this is where the surfactant comes in. Right? So here we can see what we're doing is we're breaking up this tension, right? Breaking up that tension with these surfactant molecules, right? So this is how we manage to create a situation where the same alveolar pressure in a small alveolus and a large alveolus is enough to resist that surface tension and that tendency of water to pull towards itself and try and collapse these smaller alveoli. So these little circles with these little fatty acid tails here, those are surfactant molecules. So they look kind of like our phospholipids in this image, except we've got just one tail here instead of two. And we can see them breaking up, interspersing between our water molecules. And you can see that we've got more of them here in these smaller alveoli relatively versus the larger one, right? Which means that we're able to adjust for that difference in radius and create equal pressures. So now we don't have a gradient between the pressure in this first alveolus and the second alveolus. So the air can stay in both of them at once, which means we can do gas exchange in both of these alveoli, which is great. Yeah. So that's kind of the point of surfactant, right? Which is why it's important to know about those type 2 alveolar cells, even though there are fewer of them in number. Usually in your day-to-day life, I wouldn't imagine that you have trouble creating surfactant, but this is one of the things that can be a little bit of an issue with infants. It's something they look at with preemies, I believe, making sure that they have enough surfactant to keep their lungs open and breathing in infancy. Right. So one piece of factors that can change how hard it is to breathe, so how hard pulmonary ventilation is that compliance piece, right? So if we have something that reduces the compliance of the lung, that's going to make it harder to breathe. So a reduction in the compliance of the lung could be something like more surface tension because we don't have enough surfactant. Could also be potentially tissue scarring or something like that, changes to the actual properties of the walls of the lungs. Now we want to think about another factor that can change how hard it is to breathe, which is the resistance. Okay. So we know that for our airways going down into the lungs, we have the trachea going into those primary bronchi, splitting into secondary bronchi, tertiary, going all to the different lobes and segments of the lungs, right? We get into our bronchioles, our terminal bronchioles, before we eventually hit our respiratory zone when we hit those respiratory bronchi. So we know that we have these airways that are getting smaller and smaller in diameter. Okay, so individual tubes are getting smaller. But because we have a lot of branching, this means that our overall resistance to air stays low. Our overall kind of area that air is spreading through is still pretty big, even though any one individual tube might be getting pretty small. Okay. So our resistance in the lungs is usually pretty low. And this is good because we're only working with a little bit of a pressure gradient when we're thinking about what's driving that airflow in and out of the lungs, right? So we're thinking about our good familiar flow equation, right? So we got our flow, we've got a pressure difference. And in this case, right, we know we're looking at the difference between the atmospheric pressure and the alveolar pressure, right? So we've got our alveolar pressure and our atmospheric pressure, right? That's our pressure difference, okay? And we have to divide it by resistance. And we know resistance goes up when a tube gets smaller, resistance goes down when a tube gets bigger, right? So usually we're just working with a pressure difference of about 1 millimeter of mercury above and below atmospheric pressure, right? And that's enough to keep the normal flow of air through our lungs. Yeah. However, we will sometimes see changes in the resistance of our airways, right? So if we see resistance go up, right? So if we see a change to the airway that makes it extra narrow, let's say, right? If the resistance goes up, this means we're dividing by a larger number, right? So overall, our flow rate would go down, right? Unless we create a larger pressure difference to make up for it. Okay, so when we see increases in resistance, that is what we're going to try to do initially, right? So we're going to try to create higher forces in order to make up for it, right? In which case we can keep our airflow easier. This is going to feel harder on your body. You're going to have to work harder to create this larger pressure difference. Usually, easy breathing is pretty easy, but as we see increased resistance, we might get kind of tired, right? So here we're looking at a graph of our normal oscillation in pressures during inspiration and expiration, right? So here we can see that we're looking at alveolar pressure. So this would be our PALV, right? And we can see that during inspiration, we're dipping down to -1, so below atmospheric pressure. So we have that high to low pressure going from the atmosphere into the lungs during inspiration. And then we flip it during expiration, but we just go up to +1, all right? So a little bit of a gradient, just a little bit above atmospheric pressure. So now our high-low gradient is in the opposite direction, right? Lower outside your body, higher in the lungs. So your air goes out, right? So that's our normal situation. And you can see that when we have increased resistance, this gets a little spikier, basically, right? So our amplitude has changed here on our graph, right? So now we have to get down to -2 just to have that same volume change in our lungs, right? So notice that this breath volume graph, it's not two lines, right? We don't have one for normal resistance and one for increased resistance. We're just looking at what is the force necessary to move that volume of air, just the same volume of air. Right? So you need a pressure that gets a lot lower during inspiration to move that volume of air, right? And then you need a pressure that gets much higher during expiration to move that air back out of the lungs when we see this increased resistance. Okay. So this is potentially a problem for us. We can work a little harder to expand and compress our chest a little bit more, but there's only so much room we're working with, right? And our muscles aren't all that big or that strong when we're looking at those intercostal muscles, right? You've seen them in lab. They have to attach the ribs to each other. Right? There's kind of only so big they can get. Okay. So we have some factors that can affect airway resistance, and we can also think about how well can we actually compensate when we see changes in resistance. Okay. So in terms of these factors that might be changing the resistance of our airways, we've got some passive forces, right? So we might see some changes in the transpulmonary pressure during our respiratory cycle. So remember that transpulmonary pressure is the difference in pressure between the alveolar pressure inside the lung and that intrapleural pressure in the pleural sac, right? So we see some changes as you breathe in and out, usually. So during inspiration, that transpulmonary pressure is usually increasing, getting bigger, right? So this is more of a pull on the lung, creating airways that expand and get larger, right? So as they're getting larger, right, you're making it kind of easier to move air into the lungs, right? So in that case, we are decreasing our resistance. We also typically have tractive forces at work during inspiration. So tractive, think traction, or even think like a tractor pull, pulling something. Right, so our tractive forces are the forces of tissues physically moving away from the airways. So think about like muscles in your neck, for example, kind of around the trachea, right? So you can have physical tissue kind of pulling airways open as well, rather than just a pressure difference pulling those airways open, which is the distinction from the transpulmonary pressure's effect on resistance. But in either case, both of these things would be lowering our resistance, allowing air to flow a little easier. But we're also going to see that we have smooth muscle in our airways, which could loosen up our airways, right? It could make them wider. It could drop our resistance, but it's also sometimes going to make it harder to breathe, going to narrow those airways and make our resistance greater. We also would want to take into account mucus secretion, because if you imagine, right, let's have an airway. We always do arteries in red. Let's have a pink airway, right? Okay. So here, let's think of this as maybe our trachea. It doesn't really matter exactly which airway we're thinking about here, right? But we've got some radius, right? So we've got some radius and some resistance that this radius creates, right? But now think about the effective radius we have if we fill that up with a bunch of mucus and phlegm, right? So now some of that airway is taken up by this extra mucus, which means functionally we're working with a narrower pathway, right? So more mucus is going to make it harder to breathe, which I think we've probably all felt in our daily lives. So that would be a factor that's affecting our resistance. Okay. So let's dial in a little further on the smooth muscle piece. So we've thought before about smooth muscle and how it changes radius and therefore changes resistance, right? We thought about that particularly in the arterioles when we were looking at our cardiovascular system. Now we're going to be thinking about a similar sort of effect, but on our bronchioles, right? So a new type of tube because we're in a new system, but we're going to have a similar situation, right? So our bronchioles have smooth muscle in the walls. That smooth muscle can contract. If it contracts, that radius is getting smaller. So that's bronchoconstriction, right? So for our vasculature, our blood vessels, we had vasoconstriction. Now we have bronchoconstriction when our smooth muscle in the bronchioles contracts, creating a lower radius and therefore higher resistance, okay? We can do the opposite too. So bronchodilation, right, is just smooth muscle relaxing. So now we have a nice wide bronchiole, big radius, low resistance, right? So easier for air to flow through that bronchiole. Okay. So like with our arterioles, we're going to see that this bronchoconstriction and bronchodilation, this contractile state of the smooth muscle in the bronchioles, is going to be controlled by some extrinsic factors, right? So we're thinking like nerves, hormones, and some intrinsic factors as well. So remember when we're thinking about like the effects of carbon dioxide and oxygen on the smooth muscle in our arterioles, when we're thinking about things like active and reactive hyperemia, right? We're going to see basically those same gases are going to affect our bronchioles as well. So those are going to be part of our intrinsic control. But we'll start with the external stuff, the extrinsic stuff. Okay. So unsurprisingly, we have our autonomic nervous system playing a major role here, right? So we've got our sympathetic fight or flight part of the nervous system and our parasympathetic rest and digest part of the nervous system, both playing a role in how dilated or constricted those airways are going to be, and therefore how high or low the resistance is. Okay, so let's think first about that sympathetic branch. Okay, all right. So think about when our sympathetic branch of the nervous system is active, right? That's our fight or flight part, right? So this is when we're stressed out. This is when we're going on a run. This is when we're about to start a fight, right? This is a situation where you want a lot of blood flow to your tissues because you want oxygen, because you know that you're going to have to do something active, right? We're going to break down glucose for energy so that we can fuel muscles contracting. Now that we're thinking about the lungs, we're going to think about the fact that, okay, if we're about to produce a lot of ATP, we're also going to need a bunch of oxygen for that, right? If our body's really active, we need to get oxygen to the muscles as well as the blood, right? So it's helpful for us to have bronchodilation, right? So in these stressful fight or flight situations, when our sympathetic nervous system becomes active, our airways are going to get larger, right? They're going to drop down their resistance, which means that we can get more air flowing more easily in and out of the lungs, right? So the kind of intermediary here is that smooth muscle, right? So we just relax the smooth muscle in order to have this effect. So sympathetic nerves tell your smooth muscle in the airways to relax. That relaxation gives us a wider radius, which means that we have less resistance, a dilated bronchiole, and potentially more airflow. Your parasympathetics do just the opposite, right? So we didn't think about the parasympathetics as affecting blood vessels much, but they will affect your bronchioles. And in these rest or digest parasympathetic situations, we don't need so much oxygen. And we don't need to breathe off so much carbon dioxide because we're not producing that much when we're not so active. So our bronchioles can constrict down a little bit. All right, so under parasympathetic innervation, we're going to see a contraction of that smooth muscle. So smaller radius, greater resistance, this overall bronchoconstriction. And we also do see some hormonal control involved as well when we're thinking about the radius of the bronchioles. And particularly, you're going to notice the main hormone we're thinking about is our old friend epinephrine. Right. So we know epinephrine is pretty inextricably linked to our sympathetic nervous system because of that pathway that we have from the sympathetic nervous system running through the adrenal medulla where we produce all of that epinephrine. Right? And we know that epinephrine and norepinephrine can both bind into some of our same adrenergic receptors. So hopefully, it follows pretty logically that epinephrine is going to have a similar effect to the rest of our sympathetic nervous system effects, right? So the epinephrine, same thing we saw with the sympathetics. We're going to relax the smooth muscle, big wide bronchioles, bronchodilation, more airflow. Okay. So that's what we've got for extrinsic controls, right? So we're thinking sympathetics, dilating, parasympathetics, constricting, and our epinephrine working along with the sympathetics, basically. So now we can flip to the intrinsic control. So intrinsic control, we're thinking about our local effects, right? So our local effects are going to be anything, any chemical compounds that are like hanging out right there in the tissue of the lungs. So one that we didn't focus on too much in our last unit on the cardiovascular system, but is going to play a significant role in breathing is histamine. Right? So we did mention histamine a little bit with net filtration pressure as something that's released during injury, a little bit when we thought about allergies, when we we're thinking about white blood cells, right? But histamine is something that's released in injuries out in your body, but in your lungs, what we're focusing on more is that histamine gets released during asthma attacks and it gets released during allergies. And anybody who has asthma or allergies, or knows anyone who has asthma or allergies, knows that this like visibly makes it harder to breathe, right? This is because of bronchoconstriction, right? So that histamine itself constricts our bronchioles, makes them a bit narrower, right? Makes that resistance higher. This is part of why it gets harder to breathe, okay? At the same time as histamine is released, this is also usually going to increase our mucus secretion at the same time as it's creating this bronchoconstriction in the smooth muscle. So we got kind of a 1-2 punch here with the histamine, right? We're both narrowing the airway and also sometimes filling it up with extra mucus, so making it even narrower and even harder to breathe. Okay. So that's one potential intrinsic factor controlling the radius of our bronchioles. And we'll see this last one on our list is carbon dioxide, right? So thinking about carbon dioxide, right? Think about where the carbon dioxide in your lungs comes from, right? A little bit of it is in the air, but there's not that much carbon dioxide in the air around us. When we're thinking about carbon dioxide in the lungs, we're really thinking about the carbon dioxide we have produced, right? So it's a metabolic byproduct, right? We did aerobic cellular respiration. We broke down glucose using some oxygen. We got carbon dioxide as one of our byproducts because we pulled all those carbons out of the glucose molecule, right? They end up in our bloodstream and we have to get rid of them, right? So this carbon dioxide is an effect of you creating and then burning energy. And we mentioned before as well that carbon dioxide can kind of act as an acid in your bloodstream. And we'll think even more in detail about that in our next unit as we think about acid-base balance of the blood and we think about the kidneys. So we're like adding little facts about carbon dioxide as we go through these units. But for now, you can just keep in mind that this carbon dioxide is a waste product, makes your blood a little too acidic. You want to get rid of it. That's dangerous if you're going to change the pH of your blood. So it's really important that if you have a buildup of carbon dioxide, you got to get rid of it. You don't want that carbon dioxide sitting around in your lungs. You don't want that carbon dioxide sitting around in your blood, okay? So when we see extra carbon dioxide in the bronchioles, that creates dilation, right? So bronchodilation is an effect of a buildup of carbon dioxide because it's really important to your body that you be able to breathe out that carbon dioxide easily and quickly, right? So we're going to expand our radius of a bronchiole, decrease that resistance, breathe that carbon dioxide out as quickly as we can. So those are factors that might be affecting you on a day-to-day basis, right? The only thing that we might consider kind of pathological here would be the asthma and allergies piece. But we do have some specific pathological conditions in our airways that we want to be able to name and kind of analyze in slightly greater detail. Okay. So on here, we have two pathological states that really increase the airway resistance. So we talked about the asthma piece, right? So part of the asthma was that histamine, that local factor, right? But even another piece of asthma is that we have spastic contraction of the bronchiolar smooth muscle. So you want to think like almost like a muscle cramp in your bronchioles when you have an asthma attack. It might be particularly obvious if you have like exercise-induced asthma. It might be more visible that this is kind of like a cramping of a muscle. So we can see what happens when we tighten up that smooth muscle in an asthma attack, right? And in this bronchospasm, right? You can see that narrowed airway, right? And you can even see that we've got inflammation, we got mucus buildup, all kind of happening at once here. Another very common, especially as people age, condition that would increase airway resistance is chronic obstructive pulmonary diseases. And this is kind of a broad category, but anything basically that affects these airways and increases their resistance, narrows them, makes it harder to breathe because of this extra resistance would fall under this category of COPD. Now, we're going to, in a little bit, contrast these diseases that affect resistance with what it looks like when we change lung compliance in pathological ways. So make sure you're associating these two words with the resistance piece here. But before we think about how we can diagnose a lung issue that's due to resistance problems versus that's due to compliance problems, we got to learn some terms about respiratory volumes. Okay, so we're going to have lung volumes and lung capacities. And these are going to be terms that are really good for putting on flashcards, basically, for your exam. You just want to kind of memorize these. And then we're going to use those to understand how our pulmonary function tests work, what you're looking at, why you see specific numbers lower or higher when we're trying to test someone's lung function. And then finally, we'll talk a little bit more about the alveoli, and we'll think about the air in the alveoli specifically rather than in the lung as a whole. Okay. So here's the old school way that you would test some of these lung volumes and lung capacities. So here we see a spirometer, right? So here we see an upside down bell of air, right, attached to this network of tubes, this tube that our patient is breathing through, right? We're not trying to drown them. But as we breathe in air, and there's less air here in this bell, right? This bell would sink, and it would rise when you breathe out, right? And we could connect that up to a pen and mark down those volumes of air over time. Right? So conceptually, that's how we get the graphs we're about to look at regarding our lung volumes and lung capacities. Although in reality, the devices do not look like this anymore, right? We've got digital ways to do this. Good. So we got volumes and capacities. So our volumes are going to be different than our capacities in part because they don't overlap. And we'll see what that means in a second. Okay. So we're going to have these 4 different volumes that eventually will add together to get our total lung capacity, and then we'll have some more capacities to learn as well. But let's talk first about these basic lung volumes. Okay. So let's all practice breathing easily, right? Like don't try to expend any energy. Don't try to breathe extra deep or breathe out extra hard, right? Just feel your basic unforced breath as you contract and relax your diaphragm. Should be pretty easy, should be pretty silent. So that amount of air that you're moving is your tidal volume, right? So here's our tidal volume. It's about 500 milliliters, right? So that's just the easy air that you're moving in and out during normal, easy breathing. Okay. That's not the maximum amount of air you could breathe in. And you didn't push all the air out of your lungs either, right? So that's why we have these other volumes, right? So imagine you're breathing easily, right? You go to the top of your easy breath in, right? And imagine you're in a yoga class or doing a meditation or something, and they tell you to breathe in extra deep after a easy breath, right? That extra amount that you gulp in, filling your lungs as deeply as possible. That extra part is your inspiratory reserve volume. So inspiratory for inspiration, right? Inspiration, moving air in, okay? Reserve, so think extra, right? So extra air you can breathe in, and it's a volume. So IRV, inspiratory reserve volume. Usually you have about 3,000 extra milliliters of air. You could breathe in more than your easy breath. So our usual tidal volume is definitely not our full lung volume or our full lung capacity, okay? So matching that on the opposite side, right? Go back to easy breathing, go back to those tidal volumes. And at the bottom of a breath, after breathing out easily, I want you to push extra hard, right? Push all the air you can manage to force out of your lungs. I'm assuming you're doing it. I'm assuming we have all just pushed out this expiratory reserve volume, right? So same naming convention as our inspiratory reserve volume, right? So expiratory for out, reserve for extra, and volume because it's an amount of air, right? So expiratory reserve volume, or ERV, is that extra that you could breathe out. So this is usually less than the IRV, so you have less of that kind of extra capacity here, only 1,000 milliliters, but still substantial when you compare it to the tidal volume, that easy breathing, that single unforced breath. Yeah. You'll notice, though, that these three together, your tidal volumes, that unforced breath, your inspiratory reserve volume, so that extra you can breathe in, and even if you breathe all the way out, that expiratory reserve volume, that's not our full graph, right? We didn't start any of that at zero, right? So even after you breathe out, the end of the maximum expiration, so at the end of the ERV, right, you used your abdominal muscles, you used your internal intercostals, you compressed your chest as much as you could, you still didn't like totally collapse your lung, right? It's good you didn't collapse your lung, right? Like a collapsed lung is then going to suffer from a lot of surface tension. It's going to be hard to unstick the alveoli if you totally squished all their walls, right? So it's good you didn't breathe it all out. Extra that's still keeping the tissue open, right? Still keeping your airways open is your residual volume, right? So this is this RV, right? So residual volume, that's the extra air that you can't push out even if you tried, right? So this is keeping your alveoli a little bit open, keeping your bronchi, your bronchioles a little bit open, right? So that you can keep actually breathing without extra force here. So each of these four things together, right? Our tidal volume, VT, our inspiratory reserve volume, IRV, our expiratory reserve volume, ERV, and then that residual volume, that part that's stuck in your lungs after you breathe out, but for a very good reason. All right, these are our lung volumes. And I'm marking them on the side like this, right? Because we're noticing that they're not overlapping, right? Your tidal volume isn't part of your inspiratory reserve volume. It's not part of your expiratory reserve volume. These are all like mutually exclusive amounts, right? They add together, though, to a capacity, right? So when we talk about our lung capacities, we're going to be adding together these volumes in different ways to think about someone's like overall lung function, right? Like imagine you tell someone to breathe out and then breathe in. You'd have to add together some of these, right? And you might do that with a patient, right? Like that might be relevant to what you're trying to assess. All right. So if you add together all these volumes, you get your total lung capacity, but that might not be the only lung capacity that we'll look at. So this is the second half of this graph, looking at our lung capacities, for which we have to do some addition. All right. Okay. So total lung capacity, we added everything together. That's our TLC here. Okay. So TLC, all your air. Okay. But we've got some smaller lung capacities as well. Right? So if we think about our inspiratory capacity, which we'll abbreviate IC, right? Okay. What we're interested in here, right, is just how much can you breathe in, right? So if you breathe out and then breathe in and breathe all the way in, how much air was that? Okay. So to get your inspiratory capacity, we're going to have the normal easy breathing amount, right? That tidal volume, the easy breath, plus that extra, right? So plus your inspiratory reserve volume, that extra you could breathe in, right? We just add them together. So typical amount is 3,500 milliliters, just adding together those two volumes that we looked at on the previous slide, right? We might also be interested in something called the vital capacity. So vital, I like to think about like the part that keeps you alive. That's how I kind of remember this. So the vital capacity is the total amount of air that you're moving in and out of your lungs to keep you alive, right? If that doesn't help you remember it, you can ignore that piece. Come up with your own trick and tell me. If you come up with a really great one, I'll share. Right? But the total air you're moving, regardless, is your vital capacity. Right? So that's your tidal volume. Right? So that easy breath in and out, plus your inspiratory reserve volume, that extra you could breathe in, plus also all that extra you could breathe out. Right? So your vital capacity, you'd measure, or you'd measure in a patient if you told them, okay, breathe out all the air you can, and then suck in all the air as deeply as you can, right? So force it all out, and then breathe in, right? So you're breathing in through that expiratory reserve volume, through the tidal volume, and then through that inspiratory reserve volume as well, right? So this excludes one lung volume, excludes that reserve volume, that part that's just keeping airways open, keeping your lungs from collapsing. Okay. We got one last lung capacity, not listed here on this specific slide, but it is on the image, so let's be completionists. It's probably written out on our next slide. All right. But finally, we have our functional residual capacity. So for this one, I think we mentioned it before when we were talking about the conducting zone, right? It was like the typical amount of air in your conducting zone, right? So if you're just breathing in and out normally, easily, tidal volume, right? Usually the amount of air you'll have left in your lungs after you do an easy breath out is going to be your reserve volume, right? That part that you can't get out, plus that expiratory reserve volume, the part that you could force out, but probably aren't because you're hopefully not working too hard to breathe. Okay, so we'll stop there for today. This is a great point because next time we can go into which of these do we look at and why as we're trying to diagnose different types of lung disease. All right, so I will see you all on Friday. Thanks very much.